who ever studied Greek, and I know we already had, was Mary here? So what I'm going to do, because the way we do this now, we usually say what we're going to do first, is talk a little about normal kidney function, how the kidney cleans the blood, basically, what NPS does to the kidney, and how we see it manifesting itself in the kidney. The study you already heard from Ian about that was done at the NPSW conference in Pittsburgh, that Adele and Jeff went to a huge effort to get approved by the Human Subjects Committee so we could actually study the 57 patients that were there and try to learn something. This is part of the new stuff. And how do you diagnose kidney involvement in NPS? And Ian got a little bit into that. How do you survey for it? How do you treat it if you have kidney involvement? And then frequently asked questions and or misunderstandings. Greek. So I'm what's called a nephrologist, and that's as opposed to urologist, because kidney doctor could be either one. I don't carry a scalpel, I give pills. So the surgical version is a urologist, and nephron is a little tube, there are 1 million of them in each kidney. They're how the kidney works, and I used to think it was just from the Greek for kidney, but it turns out that it also means a person's innermost feelings or emotions. So we now know, proven by the Greeks, that the kidneys are the seat of the soul. The nephron is made up of a filter called the glomerulus, which has blood flowing through it through a capillary tuft at a high pressure that tends to squeeze the watery part of the blood out into a tubule. And as that fluid, which now doesn't have any cells in it, has very little protein in it, but has waste products, but also has amino acids and glucose and salts and good stuff. As it goes down this tubule, there are other wastes added to it, and the good stuff, like the sugar, that's why you don't have sugar in your urine normally, or amino acids, even some vitamins, everything good is taken back, and what it does is turn the watery part of blood into urine. So normally there is very little protein that gets through this filter. That's one of its main functions, is to let water and wastes and the small molecules like salts and sugar through, but not to let proteins through. And the main protein in the blood is called albumin. It's about half of the total protein in the blood in most cases. And so when you see a large amount of protein showing up in the urine, this filter isn't working, basically, because it's supposed to keep it back. It's not that no protein gets into the urine. You do always have a little bit of protein in your urine. Some comes through the filter, some is actually added by the tubule. But when you have large amounts, it usually means the filter is leaky, basically, and that's not good. So this is what the filter looks like. You have a little artery or arteriole going in. It breaks up into capillary loops. The blood flows around through that and goes out through another one, but the high pressure in here and this kind of like a filtery pore through here allows fluid to go out into what's called Bowman's capsule and then into the tubule, which goes on, has cells lining it that take back good stuff and put bad stuff in. So this is the basic plan for the kidney. Again, of these things here called glomeruli, there are about 1 million per kidney. This is looking at that filter from the outside. This is not, they are not blue and purple. This is pseudo color. This is a scanning electron micrograph, and this is the cell that I started studying in Germany when I did my fellowship in the 80s. It's called the podocyte, more Greek, podos, foot, podiatrist. And the podocyte is a big octopus that sits on top of these capillaries and has branches coming off and branches from the branches and branches from the branches until neighboring podocytes completely, so this blue here, you can get an impression, and I'm completely myopic and I can see it. So some people should be able to see that basically you can't see the capillary underneath there. It's completely covered, and there's little slits between where the little foot processes to come through, and that's where the fluid goes through. And the slits are actually bridged by a membrane that keeps the protein in. So this is a very intricate thing. These cells, as far as we know, don't replicate. So they're kind of like what we used to say about neurons. You're born with a certain amount, and all you can do is lose them. And what we've looked at, I don't want that one, but what we've looked at is basically what does loss of these do to progression of kidney disease. So that's what I'm interested in. If you cut through this membrane, so this is the inside of the capillary, and red blood cells would be in there. You don't see any there now. These are the podocytes on the outside, and these are the little foot processes, the little finger-like things. And you can imagine if you cut your fingers along this way, you'd see just kind of a cross-section. And so what happens is, this is for a capillary, very high pressure. Usually capillaries have pressures of maybe 5 millimeters of mercury. It's about 50 millimeters in here, because the idea is to push the fluid out. An adult will filter through this space in the kidneys 180 liters, 180 quarts of fluid a day, so that's how you keep the blood clean. You push out stuff that's good and bad, you refine it so it's mostly bad, and you end up urinating maybe a liter and a half a day out of that 180. So most of the water comes back, most of the salt comes back, but this is the primary filter here, and little slits between the lining of the blood vessel and then the tiny little, what we call filtration slits between the podocytes. So going back, this is what's called the glomerular basement membrane. It's made mostly by the podocytes. It doesn't have a great effect on things passing, so it shouldn't keep water from passing. You don't want that to happen. It doesn't really keep the protein in. The protein is kept in by the little slit diaphragms here, but it's structurally very important because there are very high pressures in here. So this is a normal basement membrane, a normal thickness. You see it's extremely homogeneous, very just solid gray. But in Nail Patella Syndrome, it looks a little different. So this is a biopsy I did on a certain patient with Nail Patella Syndrome many years ago. Here's the capillary lumen. This is where the blood cells would be. Here are the podocytes on the outside, but this is the basement membrane. So you see it's much thicker, if you remember the size of these little podocyte things, that it went down to about here, and it's much more heterogeneous. It's not this solid gray, and in fact there are these little specks in it, and that's collagen. Remember, Ian talked about collagen being one of the structural proteins, and the collagen you find in this is type 4 collagen. It's very specific for a basement membrane, and in fact, in Nail Patella Syndrome, what you find is fibrils of type 3 collagen in it that shouldn't affect its function too much. We're not sure why there's protein loss, but you can just certainly see that the basement membrane is very affected in Nail Patella Syndrome. And if you are a kidney pathologist and someone gives you this picture to look at, I would expect you to say, just kind of like the iliac horns, that's Nail Patella Syndrome. They don't need to know anything else. So what happens in the kidney with Nail Patella Syndrome? Well, remember, Ian talked about this transcription factor. Again, that's a gene, the protein that is made from which regulates which genes are turned on where, other genes. So it's a master controller. And in fact, in LMX1B, it's often a master controller having to do with the development of the body, whether things are kind of on the right side of the body, so-called dorsal ventral specification. And so that's what we normally think of as its function. So in the kidney, LMX1B is made in that octopus cell. That's the cell that makes it. And it must be important for the cell. And there's another very unusual thing that when I first got involved with this, I didn't know the podocyte, which I'd been working on for 15 years, was involved with Nail Patella Syndrome. That became clear to me later. But the interesting thing is, in development, you only need LMX1B to determine dorsal ventral during development, while you're in the womb. But the podocyte expresses LMX1B throughout life. So it means it's not just needed as a podocyte's developing. It is needed for podocyte development, but somehow it's regulating how the podocyte works even after you're born, and that's something rather unusual in terms of what we'd call a target for LMX1B action. This is Chenonceau in France, where I've been. This is a commercial. No, this is just to get people to wake up and relax. Okay, so LMX1B was, Nail Patella Syndrome was described first time the end of the 19th century, so a very long time ago, from the obvious features one could see from the outside. So the kidney involvement was first clearly recognized, although there's German literature that I think reported on 6 cases from the 20s or 30s, 4 of which had significant kidney involvement, so they didn't quite put it together. I think that was Kiesler or something. But then in 1950, 53 years after the first description of the obvious orthopedic findings, somebody said, gee, I think that the kidney's involved in Nail Patella Syndrome. And there have been a number of large studies, and large means actually for Bill Bennett's study, which is a very good one, 3 dozen. So that, for a lot of things, wouldn't qualify as large, but as you can realize, for Nail Patella Syndrome, to get that many patients together, it was a trick. Marié in France had more than that. Liz had 120-something, and Bongers in the Netherlands had, I think, maybe the biggest of, but still maybe under 200. And they just accumulated people from all over Europe. So we studied 57 adults and children with Nail Patella at one of our meetings, which actually makes it a pretty competitive size, although we were criticized grossly for it being a convenient sample, and somehow we didn't go door to door to, let's see, 1 in 30,000 times, what, 100 people, 300,000 households to find. So the most common thing, as Ian referred to, is mild to moderate proteinuria, and that's abnormal amounts of protein in the urine. And remember, depending upon how you test it, if you use the dipstick the doctor does in the office, that's extremely insensitive. And that's kind of how early things were done. They were picked up that way. So using the sensitive methods, for example, that are used on diabetics, where early protein in the urine is a very important thing to find, we have laboratory methods which are way more sensitive and may pick up more mild cases. But this is kind of the standard number that's used of proteinuria, basically, that's high enough that the doctor does the dipstick, you'll find it. Also, in a fair amount, 10 to 20%, there may be microscopic blood in the urine. And that wouldn't be a big surprise with a kidney glomerulus disease either, but it's probably quite variable because, again, how closely you've looked. Now, the nephrotic syndrome is a syndrome. A syndrome is not a disease. A syndrome is a constellation of findings. And in the nephrotic syndrome, it is large amount of protein in the urine, low amount of protein in the blood, and swelling. And also high blood cholesterol, but that's not always found. So if you have that, it's a nephrotic syndrome, which has numerous causes. It tends to be associated, other than one childhood cause of nephrotic syndrome, which is easily treated with steroids and is recurrent, but basically in most people, every time you treat it, it just goes away again. Most forms of nephrotic syndrome are not a real good predictor of how your kidneys are going to do, and the same thing is true for Nail Patella Syndrome. So nephrotic syndrome is associated with swelling and massive amounts of protein in the urine, and the numbers vary, but it's probably less than 10% in patients with Nail Patella Syndrome, and it is a bad predictor of how you're going to do with your kidneys, and we tend to, that's one thing we survey for. So patients could have a kidney biopsy looking just like that one you saw that a good renal pathologist would look at and say, Nail Patella Syndrome, and have no abnormalities in their kidney. So the fact that something looks like it's built wrong in the kidney, and we suspect that if you biopsied any patient with Nail Patella Syndrome, it'd be one version of that. It would look that type of way. It apparently has very little to do with how the kidney's working. As Ian also referred to, the disease is very heterogeneous, and in fact, there have been families found. So again, you know, if 2 members of a family have Nail Patella Syndrome, they have the same mutation. It wouldn't be, oh, they just happen to each get a new spontaneous different mutation. So 2 members of the family with the disease have the same mutation, and you may have someone in kidney failure and another one with no obvious kidney involvement. So it isn't as simple as, oh yeah, the disease caused that, and Ian was referring to that. It's in a milieu of your 23,000 minus 1 other genes. They all interact in one way or another, and even though, you know, two people in the same family must have the same mutation for LMX1B, they can have those little spontaneous mutations. One has one and the next one doesn't, and it's the two together that cause the thing. So some families even have been found to have Nail Patella Syndrome without any kidney involvement, and we'll get even weirder later. So we did this study, this convenient sample of 57, part kids, I don't think it was quite half and half, and part adults. And here's a great example. We found, and we did a questionnaire, so it just asked, you know, are on any medicines for this? Do you have high blood pressure? And one thing that was asked is, have you ever had a kidney stone? And I've already heard here from some people who have that problem. And gee, it was 5 out of 57. My God, it must be a part of Nail Patella Syndrome. But then if you look to the literature, and strangely, even though I can't turn over my hand, just like Ian was saying, and I've had a kidney stone. But 10% of adults in the country have had a kidney stone. Let's see, 10. 5 divided by... So it seems impressive. It must be a part of the syndrome, but the fact is it's just probably coexisting with something that's a pretty common condition in everybody else. There have been kidney diseases associated with it. And again, kidney diseases, the big severe ones, are kind of rare things, and it's kind of like, well, I got struck by blue lightning, and then, you know, a year later I got struck by red lightning. You know, rare things happen rarely, and to have a couple of rare things happen to one person, there's a tendency to say they must be related, you know, because that just couldn't happen. You couldn't win the lottery twice. Well, I just had a new patient come to me as a baby with Nail Patella Syndrome, and within a year he developed hemolytic uremic syndrome, which is a very severe cause of acute, usually reversible renal failure due to an E. coli infection from a particular E. coli. It's the jack-in-the-box disease for anybody from the Northwest, or the Odwalla disease, so it tends to happen in epidemics as well as endemic cases. And that's actually, strangely, the kind of connected disease that you see more often than others with Nail Patella. There's no way I can connect them to say, oh yes, there's clearly a connection between hemolytic uremic syndrome and Nail Patella. But having been impressed in the past, and I didn't put it in this slide because I kind of have a tendency to believe it's not the case, I've literally had a case myself where a kid has had both. Here's the one that's important, and it was referred to earlier by Ian. In the general population, somewhat dependent on your parity, whether you've had kids or not, and your age when you're pregnant, about 2 to 6% of the general population will have something called preeclampsia, which is an extremely severe disease brought on by pregnancy in women. And what Liz found was 29%. And that does seem to be a bit different. I mean, that may be 5 to 10 times the background risk, and that's worth paying attention to. This is Thailand. So the study was organized by Adele, and a number of us participated in it, the strong work being done there. And then Sam was involved in looking at eyes, and Jeff Towers took, you know, so a lot of people did a lot of things. Steve examined, you know, we did well. The kidney stuff, I tried publishing over and over. I sent it to the Lancet in England. I thought it was very important. And 4 different journals, and they all said, no, it's a population of convenience, you didn't design it right. So I actually wrote a review on kidney disease and Nail Patella Syndrome that was published in '09, and I just threw the study in there because it was the only way it was ever going to get published, apparently, and so at least it's out in the literature, and again, it was due to the participation. Oh, and there are copies, especially. And I'll just say now, I am very happy to be called by anybody's kidney doctor. I guarantee you, you are not going to find kidney doctors that know about Nail Patella. Again, they might do what I did the first time when Jane Zaretsky called me, and you just open up your textbook real quick and you're looking. But I've not only seen and talked to dozens and dozens of patients, I've read every paper published on Nail Patella and the kidney, which, believe me, was not a huge amount of reading. So I'm happy both to learn from other people what their patients are telling them, but to give them my experience, or just to send them a PDF copy of the paper. So 57 subjects that did questionnaires. We got blood pressures in 46, blood in 39. That would have been a little less among the kids. Urine samples in 47. So you can imagine 57 were willing to fill out a piece of paper, but 10 weren't willing to pee into a cup for you. And it was basic. Again, the effort put in just to getting this was incredible, but we didn't do anything fancy. We didn't do MRIs on the kidney. So we looked at the serum creatinine in the blood, and if we're going to talk about kidney function, the kidney does a million things. Remember, it's the seat of the soul. It does all these things, but if we have to have one number, if you talk to a nephrologist and you want to say, how is my kidney doing? Usually it's, what's my serum creatinine? And the creatinine is made constantly by muscle, so I have a lot of creatinine in me, excreted by the kidneys. So as your kidneys stop working, your creatinine goes up. It builds up in the blood. If it goes down, that's increased kidney function. So it goes inversely with kidney function. In the urine, we looked at the albumin-creatinine ratio, sometimes called the microalbumin. And this is what's used in diabetics. This is an unbelievably sensitive test for kidney damage and protein in the kidney you would never find by a dipstick. So that's kind of what we had for kidney function, as well as the blood pressures, which is a function of the kidney in the patients. Of the kids, all 10 kids who gave blood had, by what you can tell from the serum creatinine, they had normal kidney function. Actually, they had somewhat more than normal kidney function, and there are some reasons for that. What is to say, apparently more than normal. None of the kids had high blood pressure. But 6 of the 17 kids who had urine specimens had abnormal amounts of protein in the urine. Remembering, we used a really, really sensitive method. So it wasn't a dipstick, it was a really sensitive method. 4 of these 6 only had mildly abnormal. It would have been missed by a dipstick. So they would have been seen as not having it by a less sensitive method. Of the adults, the estimated function was actually decreased under the normal range in 2 of 29. Which is probably more than you'd find in the background population. We have 20 million people running around as adults in the United States with chronic kidney disease who don't know it. So again, there is a certain background incidence to people who have decreased kidney function and don't know it. 2 of the adults had blood pressure. It was mild hypertension, blood pressure issues, but some were on blood pressure medicine, so probably is a little bit more. But again, if you ask how many adults in the US have high blood pressure, it's a pretty large number, so they were not impressive for their blood pressure. 8 of the 30 adults had abnormal amounts of urine albumin. 5 of these 8, remember the kids, mostly it was mild. 5 of the 8 was pretty high amount. And there's a medicine that is used by kidney doctors often in diseases of the kidney that have protein in the urine. They're called ACE inhibitors, or they're the prils, lisinopril, enalapril, ramipril, benzonapril, etc. Only 2 of the 5 people with protein in the urine, and some of which were known to their doctors to have it, were actually on these medicines. So it was not being addressed or taken seriously. So one thing that was a finding of it is if you look at kidney function, it goes down with age. We burn out our kidneys over time. It's generally said that from age 40, you lose 1% of kidney function per year. So when are we all going to run out of kidney function? At 100. Well, you know, we mostly have other problems before then. So we tend to be over-endowed. Unlike rats, which I used to study, they die of kidney failure. If nothing else is going on, you just leave them in the cage and whatever. Humans tend to get strokes and cancer and heart disease. If we live to be 120, we'd be in trouble, but we don't make it that far. So normally it's 0.5 to 1% over 40. What we found in our Nail Patella patients compared with 138 matched adults over the same age range at Stanford that I got the serum creatinines for and used the same estimation equation for what's your kidney function. Our Stanford people that were normal controls basically were in that range. They were about a half, and this is just the unit of loss. We could consider it kind of like a % of kidney function, 0.5% per year. And our patients with Nail Patella Syndrome were 1.29. So it was significantly high, but the fact is you don't see people with Nail Patella Syndrome just going into kidney failure with old age. So again, we're just not getting old enough for it apparently to be an issue. And here's the graph. So the big, as you would expect, the big circles are Nail Patella Syndrome individuals. And the dotted line is a straight line curve fit to their loss of kidney function. And then the little dots are the unaffected controls. And this line and the slopes of the line are statistically significantly different. So there is a faster than normal loss of kidney function. But remember, we only had a couple of people. I think these two literally were outside the normal range for age in terms of their kidney function. So summarizing it, kids and adults have basically the same frequency of protein in the urine if you use a sensitive method, although it's a little bit higher in kids. You can't really say they're different. It certainly was not progression. It certainly is not more and more people get protein in their urine with age. And that's unusual. For progressive kidney disease that are characterized by protein in the urine, generally speaking, you expect it to get worse in age. So already a place Nail Patella Syndrome is a little unexpected that it doesn't seem to be progressive, nor when you looked at the people who had lower kidney function and higher protein were those two correlated. And that's also not the case for most kidney diseases. So it's a number of aspects of it. You have protein, you have some loss of kidney function, but it's not quite working like most of our kidney diseases. My hypothesis is that thickening of that basement membrane is why you're losing more fast than normal the kidney function, because you're trying to push fluid against something that's getting thicker and thicker. And even though it may be pretty water permeable, we don't know if it is as water permeable as a normal basement membrane. It's certainly just thicker alone would mean it's harder to push fluid against it, and so how much fluid goes through and get clean would go down. So that's my hypothesis that would predict with time that gets thicker in subjects with Nail Patella. But we basically have no examples of people being biopsied 2 times and the thickness being measured. The rare form, which can happen in 6, 7, 8 years of age, teens, 20s, of people having nephrotic syndrome, huge amounts of protein, and going into kidney failure, I hypothesize is due to the presence of the LMX1B mutation, and one of the genes in that pota site that LMX1B tells when to go on and off has a mutation. And it's a mutation that in and of itself wouldn't do anything. It's what Ian was referring to as autosomal recessive. Only one of the parents' genes is bad, and again, in most genes, that's not enough to cause a problem. But if you couple it with the LMX1B gene, it is enough. And that would explain why in the same family, you can have 2 people with Nail Patella, one has kidney disease and one doesn't, because of course that other gene, they don't necessarily segregate together. So they're not right next to each other as can happen in some. So that's been my hypothesis, almost impossible to determine, but it sounds good. That's Chenonceau, and that's across the Cher River in the Loire region of France. So, for those people I've been tantalizing for the last day, there have been 2 papers. One is out and one is not yet out. So I reviewed the one that's not yet out. And the first one that's out in the Top Kidney Journal was looking at a patient. They were studying causes of the nephrotic syndrome, genetic causes, and they biopsied the patient, which is very, very common, especially in adult patients if they have nephrotic syndrome, because it's pretty hard to tell what they have. You do a biopsy, make the diagnosis. And guess what? The biopsy looked like Nail Patella Syndrome, just like that electron micrograph you saw. Only one tiny little problem. This patient had none of the findings outside the kidney of Nail Patella Syndrome. So this group in France went back and they had 74 families that had autosomal dominant, remember what Ian said about the inheritance pattern of Nail Patella Syndrome, focal segmental glomerulosclerosis, which is a nephrotic syndrome that causes kidney failure. And they went back and they said, okay, we found one with this particular mutation, which was a newly described mutation in Nail Patella Syndrome. It is in the gene, but it's a place that hasn't been described as having a misspelling before, and it was one of the misspelling mutations. And they found 3 more families with either the same, all of them were in the same amino acid, and 2 of them, I think, had the same actual mutation. One had a different mutation, but it was at the same place in the gene. And then I reviewed a Japanese case of a single case that, interestingly, was a child who was biopsied, and had findings of Nail Patella Syndrome without any skeletal or other findings of Nail Patella Syndrome. And that child had a mutation in the same mutation as most of the French. So they were all in an arginine 246, so that just means it's the 246th amino acid along the protein as it's expressed.
Is that in a new paper?
How comfortable are you with the thoroughness of the investigation?
Interestingly, the French was one of the top genetic renal disease groups in the world. So in terms of the genotyping and everything, that's clear. The Japanese was a single patient, but they did a much more sophisticated analysis. They looked at the function of the gene in vitro systems, which is pretty unusual. And so I've written an editorial. I was invited to write an editorial about it, and I really try to make a very big point about that we really need to stop saying there's a mutation in the gene and ask what it does. Because clearly here is something in, and Ian will go into the homeodomain and the limb domain. So the gene kind of has two functional parts. One that underlies how different proteins work, different transcription factors may work along with LMX1B and its function. They interact with the limb domain, and the homeodomain is where it gloms onto the DNA and says, open up this spot and read this gene off and make a protein from it. And so these were all in the homeodomain, and they did look in Japan at how it could activate test systems, and showed it actually had functionality. And so the guess is it has functionality for things that affect your formation of the skeletal system and doesn't have functionality in the podocyte.
I have a cousin who has juvenile kidney problems, and he's had severe problems since he's about maybe 12.
With Nail Patella Syndrome?
No.
Oh.
No, well, I don't know.
Well,
I wonder because
usually, again, you're not going to miss it. If someone who knows Nail Patella has examined him, you're not going to miss
I don't know
it.
if they have or not.
Well, that would probably be a good idea. So,
Yeah.
so that's just something that's actually brand new. Only one of the papers is out. You know, simultaneously, groups from all over the world have found that there is, and it's interesting because we know this doesn't apply to any of you, because it's a different mutation that doesn't have any skeletal effects, but has the classic effects and actually bad effects. And it's unclear because the French group was all people with a very bad disease, so they may have picked, you know, kind of the tip of the iceberg type of thing. It may be more common and milder. But it just shows there can still be new things happening that may tell us to be a lot more sophisticated in how we analyze mutations. That it's not just the mutation in the gene, it's like, and what does it do to the function of the protein coming from that gene? So how about diagnosing kidney involvement? Again, as I said before, the older literature was based upon insensitive tests. It was kind of, you know, standard for the time. But the newer studies, we actually used a method that was sensitive enough. We may be picking up more, but more milder cases. So when is it we should screen for kidney involvement in Nail Patella Syndrome? In my opinion, it may have come out a little different from Ian, that until a kid here's a cup, pee into it, which, being a pediatric kidney doctor, I'm pretty good at getting kids to pee into cups. But that's off, and I've gotten kids less than 2 to pee into cups, but it's usually by little boys standing there and mom having the cup and just being ready to go. If the kid has nothing else wrong, okay, there is no swelling, the kid is growing well, the kid is apparently happy, healthy, everything's going as it should, I don't think you need to test until you can get the kid to pee into a cup. Don't put a bag on or anything. If there are any problems, obviously you're going to want to test if it's in a child with Nail Patella Syndrome. If you happen to go to your doctor and they say pee into a cup, and you're old enough to pee into a cup, and they do a dipstick and they say, aha, there's protein, have them check it with a real method. You know, the albumin method costs $4. It's not really, and it's the most sensitive. So have them just make sure it's real. And if it's real, what you get is just not, oh, it's 2+ or 3+ or something. You get a number. You get it's 0.8 or it's 8.8. And that can be pivotal in saying whether you should be sent to a kidney doctor. So if someone finds nothing in a concentrated urine by dipstick, probably you don't have protein. I would still be inclined to say, I want the quantitative one. I want to hear how not much protein I have, because a dipstick's not very sensitive. But if someone finds something, they should always verify it with one of these kind of real methods, which they send to the lab rather than do in the office. And then if it's high enough, or if there are other problems, you probably should see a kidney doctor. Is a biopsy necessary to diagnose? I did a biopsy in my first case. I thought it was indicated. I probably wouldn't do it for someone just with Nail Patella Syndrome again, because again, what we know is you can have something that looks like classic Nail Patella. Patient's not going to have a kidney problem. It's just not needed to diagnose the syndrome, and it doesn't predict how you will do kidney-wise. So it's not going to bring you information just if all you have is someone has Nail Patella Syndrome and maybe a small amount of protein in the urine but no other problems. However, if there's something that's not typical, you have a lot of swelling, you have a huge amount of protein. If, in fact, you have other indications, oh, I have lupus and Nail Patella Syndrome, well, anybody with lupus and kidney findings, I biopsy. So don't let Nail Patella Syndrome put blinders on if there's something else. You've got diabetes and Nail Patella Syndrome and protein in your urine. Just kind of put the Nail Patella Syndrome over to the side and say, what would you do with someone who's diabetic and has protein in the urine? You very well might biopsy them. Or, in fact, if there's an indication by the increased serum creatinine of decreased kidney function or a huge amount of protein, those might be indications. Many kidney diseases cause protein and hematuria, so this is just kind of a repeat. So if you have NPS and have one of those things, don't let your doctor turn the key that says, I don't need to think anymore. I'm just going to, everything that happens to you is Nail Patella Syndrome. You are not Nail Patella Syndrome. You have 23,000 minus one other genes. You have environmental influences. You have all sorts of things. So even though we know a lot of things are associated and we do want to bundle and bunch things together, don't let your kidney doctor stop thinking, or your general doctor stop thinking early. You know, if something fits another disease, and follow that out and just make sure you know it. And in fact, in hematuria, if you just take 100 kids in grade school and get them to pee in a cup, you get up to 5% will have, by dipstick, blood in their urine. And then if you say, let's do it twice, that drops to about 1%. Let's do it 3 times. Those who all 3 times have blood is like a fraction of a percent. So there's a fair background of positive blood in the urine in people that probably don't have any disease. So bottom line, don't short-circuit the diagnosis. Don't say it must be Nail Patella Syndrome because I've got that and there's some other thing. You're not going to be able to fit everything in a Nail Patella Syndrome. So if something else would also fit, just work that one up too. Maybe it's the problem, maybe it isn't. So prognosis, heavy proteinuria is a bad prognostic sign in most kidney diseases, and it seems to be in Nail Patella. Even though, as I said, for our Pittsburgh study, you don't find this tight correlation between decreased kidney function and protein. Very high protein, the nephrotic syndrome, is usually a bad predictor. We don't know what these magical medicines called the ACE inhibitors, the PRILs, will do. We know in people with decreased kidney function and protein in the urine from other causes, they are remarkably protective of the kidney in a non-specific way. They don't treat any particular disease. They protect the kidney magically, is all I can say. And the evidence from Pittsburgh is they may be being underutilized in Nail Patella Syndrome. However, we don't have any study that says they're effective in Nail Patella. Again, it would be a very hard thing to do. You know, find me 50 patients with Nail Patella Syndrome, we'll flip a coin, half of them will take an ACE inhibitor, half won't. We'll follow them, you know, you can imagine this is not likely to happen. There's a wide variability, even within a family with the same LMX1B mutation, of how the kidney is involved, probably due to the influence of non-LMX1B genes. And so just remember, you don't expect everybody to be the same, even if they have the same mutation. So how do you treat it? There is no specific treatment, and that would be the case for basically everything having to do with Nail Patella Syndrome. Proteinuria is an indicator of damage to the kidney, but it doesn't tell you what it's from. So many kidney diseases have protein in the urine. We do have the non-specific treatment with the ACE inhibitors, or this newer version that works through the same hormone system called the ARBs. So I used to take lisinopril. So not only can I not turn my, but I got the lisinopril cough. And so it was waking me up, and as a physician, coughing around patients, it's, you know, they don't. You say this, I'm on ACE inhibitor, don't worry. So I switched to irbesartan. So you've got the prils and the sartans that works in the same hormone system, but doesn't have, basically the cough is about the only side effect that it doesn't have from those drugs. And what we know is in a lot of kidney diseases, these are unbelievably protective. So even though we don't have direct evidence in Nail Patella Syndrome, most nephrologists' gut impression would be you've got a potentially progressive proteinuric kidney disease. You should be on either or, and then some people actually put the both together. So they're very, what we call renoprotective. There have been no studies in Nail Patella Syndrome, but that very same courageous individual who let me put a needle in his back and get a little piece of the kidney had protein, and remember, if you do it the right way, you get this number. It's not 2+, 3+. Had these values of ratio, not of albumin to creatinine in his urine, but total protein to creatinine, of 2.2 to 2.8, where normal is basically under 0.2. So that's fairly elevated. I see people 40 and 50. I mean, so 2.2 to 2.8 is not. We see people in the teens and 20s, so that's abnormally high. It's not through the roof. And on lisinopril, he dropped to 0.8. Again, never been studied, not in a scientific way, but our gut belief in the kidney field is if you have someone with abnormal protein and you treat and the protein goes down, you are protecting the kidney. It's just kind of a tenet. It's almost a religious tenet. Due to the risk of preeclampsia, which seems to be 5 to 10 times the background risk, any woman with Nail Patella Syndrome should consult with a high-risk OB before getting pregnant and probably see an adult nephrologist and make sure she could sustain a pregnancy, because if you have decreased kidney function, a pregnancy can really damage your kidneys, and it's very important to know your kidneys would be okay, and you have an adult nephrologist lined up, and you have a high-risk OB, and you are monitored. I was just called by a dear friend of mine who's also a swimmer, national champion, whose daughter-in-law had eclampsia in Switzerland and almost didn't make it. It's a very serious disease. So you want to know if you're at risk of it. You're not getting the normal monitoring, you're getting extra monitoring. But remember, the ACE inhibitors and the ARBs cause birth defects. They hang out in the body a long time. So if you're being treated with them and you're anticipating getting pregnant, and make sure it's an anticipation and doesn't just happen, you have to be off of these medicines for a substantial time before getting pregnant. They cause birth defects through all 3 trimesters.
The male and the male?
No, just the woman.
Okay.
Yeah, good question. Kidney transplant gets done in Nail Patella Syndrome because some people, no matter what we do, they're going to go on and lose their kidney function. There are diseases, actually some of our worst diseases, some of the causes of focal sclerosis with nephrotic syndrome recur after transplant. And they bother us no end because, you know, we think we're kind of fixing someone up and it just comes back. Nail Patella Syndrome is not one where the disease comes back. It's most genetic diseases, kidney was formed wrong or something's happening wrong in the kidney, you put in a kidney that's not involved, it's going to work fine. So kidney transplant is always an option for kidney failure unless there's some other life-threatening problem you have, and it's not going to be the case that Nail Patella Syndrome comes back. So frequent questions: what should I eat, drink, or take as over-the-counter, or what should I not? Even if I don't have obvious kidney involvement. If you have obvious kidney involvement, then the answer is you ask your kidney doctor what you should eat, drink, not eat, drink, what medicines. So low-protein diets you may see if you go online protect the kidney. And if you're a rat that's had one kidney taken out and half of the kidney infarcted, they are very protective. They have not ended up being quite as protective in humans. And there was a very big study in the 90s, $100 million study, that showed they virtually had no effect. And if you had people taking the ACE inhibitors, that was much, much more effective. So we don't recommend low-protein diets to protect the kidney. They're just really not effective enough. I hear from, about every other person I ever talk to about the kidney, how, oh, I drink a lot because it will clean out the body, it washes out the body. Not the way things work. You don't want to be dehydrated, and I've had a kidney stone, and so I try to drink a fair amount. But you don't wash things out of the body by having more fluid. You pee more by drinking more.
Yeah.
But that doesn't do anything for the waste. The wastes are eliminated by the kidney if it's working right. It is a myth. Although, again, remember, 10% of adults get a kidney stone, and most of us don't drink enough, so there's something to be said for that. No.
Would it still push more fluids through?
No. Not through the filter. The filter is where it counts. And that is driven by blood pressures and such. What it does is less water is reabsorbed because the kidney is the seat of the soul. And it says, a lot of water coming in, my blood is getting dilute, I need to let a little more water get out to keep everything in balance. So that's why, all sorts of things, but it doesn't eliminate waste. NSAIDs like ibuprofen, naproxen, Advil, you know, there are a million names for even the same ones, are statistically associated with an increased risk of kidney failure. Now that's over a background population, and it's a large increase, it's 4 or 5-fold, but of course the risk of kidney failure in the background population is not huge. That's ibuprofen.
If you took a lot of that over a period of time and then stopped,
it can still do the damage. And the problem is it's a lot. This is not someone, I take ibuprofen twice a week. It's literally someone who takes kind of a maximal dose every day.
I did for a few years.
Well, this is the problem because, of course, Nail Patella Syndrome has a lot of joint involvement and arthritis risk and has things that cause pain. And you just have to be aware, because they are good for being anti-inflammatory, but there's a problem with very large amounts. Herbs and naturopathic medicine. Again, the data is it really takes years. Oh, the question is, actually I could hardly hear the question.
Yeah, it took 3 years.
My practice, because I'm cautious, if they're taking consistently for 3 months, I'll send them for a function test and a blood function test, just to make sure there's no.
And you may be picking up someone that has actually has occult kidney disease that will be made worse by it. So that might be earlier. But someone who started with normal kidneys, it does take years, but it will destroy the kidney in years if you're taking very large amounts. And you're probably familiar with the stomach protective NSAIDs that came out some years ago that people were pushing a lot, and it turned out the heart attack risk went up a lot. And the fact is, you have to remember every risk, every benefit. So if you can't walk and your life's being destroyed because of something that can be fixed by that medicine, you may be willing to take a risk for something else. You just kind of have to know what the risks are. Herbs and naturopathic medications, I can't even keep up with the allopathic medications I use. So generally all I can say is, and I just read a wonderful review in the New Yorker on Balkan nephropathy, is there's something called Aristolochia, which is a plant used in Chinese herb shops. Aristolochia. And it makes aristolochic acid. And people give it in Chinese herbal medicine, and 100,000 people or more in Asia every year have kidney failure because, in fact, it's toxic to the kidney. So natural does not mean safe. Okay, so these are just some references. You could feel free to read any of these you want, but...
Take a picture of that.
When you said nephrotic syndrome is when you spill a lot of protein and then you start to swell. Those are the 2 criteria, then it becomes
There's three criteria I use. There are 4 formally. It's nephrotic amount of protein in the urine, so this has to be a quantitative amount. low protein in the blood, swelling, and then usually high cholesterol goes with it. So those make the...
Chronic syndrome versus just proteinuria, spilling protein, are you then at higher risk of going to kidney failure?
The cutoff is in most large studies is something beneath the nephrotic range, but there's an argument. So the nephrotic range is in this ratio 2. Over 2 is nephrotic, under 2 is subnephrotic. And probably there's evidence if you're under 1 with a chronic kidney disease, you're not necessarily at increased risk of progression. So it seems to be, but it's near the nephrotic, given that we get people 8, 10, 20. You know, if you're there, that's not a good sign.
Swelling is like ankles.
Yes. So around the eyes, ankles, hands. Yeah.